So today's topic is basic microbiology. So it means I have to cover something about everything, which is like impossible. So we'll be covering some important facts. Okay? And most of you will be knowing these facts. So starting with the classification. We know that microbes which have the potential to colonize or infect humans can be broadly divided into 4 groups. These may be bacteria, these may be viruses, fungi, or parasites. And bacteria are the major group of pathogens across the world. So if we classify bacteria, we have to classify bacteria. We differentiate all the bacteria into the gram-positive or gram-negative bacteria. This is the result of a simple staining procedure known as gram staining. And the outcome of staining procedure is such that some bacteria appear purple, while others appear pink. So in the picture below, you can see that there are spherical bacteria which have stained purple. So spherical means they are foci, and since they are purple, that means they are gram-positive. So gram-positive are purple ones. In the same picture, you can see that there are pink rod-shaped bacilli also. These ones. Rod-shaped means they are bacilli, and pink means they are gram-negative. So these are gram-negative bacilli. Another way of classifying bacteria is based on the requirements of oxygen. So they may be classified as aerobic or anaerobic bacteria. Coming on to the next group, viruses. They can be DNA viruses or RNA viruses. Then fungi. Fungi may grow as single-celled yeast forms, or they may be multicellular molds, which grow into filamentous kind of thing and produce mycelial colonies. So can we name some yeast? Anyone? Candida, yes. Cryptococcus, you must have heard of it, right? Molds, any example? Aspergillus, mucorales, all the agents of mucormycosis, and many others, Fusarium, Penicillium, dermatophytes. Okay. Certain fungi are dimorphic, which means they stay in 2 morphologies, depending on the temperature at which they are on which they are staying. They can be yeast also at the temperature which is close to the human body temperature, and they can survive in mold form also, which is when they are taken when they are kept at room temperature. So any example of dimorphic fungus? Histoplasma, yes. Where have you heard of it? Endopeople. Patients with bilateral adrenal enlargement, many times biopsy comes, and small yeast cells are seen. They are histoplasma. It is one of the major causes of such kind of presentation. So next group is parasites. Parasites also can be unicellular, which are protozoa. Protozoa, examples. Entamoeba, yes. They may be commensals or pathogenic, yes. Entamoeba, histolytica, which causes dysentery and amoebic liver abscess. Then Giardia. Then, yes. Naegleria, yes. Opportunistic parasites also like Cryptosporidium, Cystoisospora, Cyclospora. And agents of malaria, Plasmodium species. Then agent of Kala Azar, visceral leishmaniasis. It is caused by Leishmania donovani. So these are protozoa, the major important protozoa. Then helminths. Helminths are also parasites, but they are multicellular and worm-like. These are basically worms. For example, anyone from this side? This side is not speaking. We are sleeping, I guess. Ascaris, yes. Second. Okay, roundworm, hookworm, pinworm, Ascaris, Ankylostoma, and Enterobius. Strongyloides also, you must have heard of Strongyloides. Okay, so this is a major group of pathogens. All these pathogens can stay as commensals, or they may just colonize or produce infection, ranging from being asymptomatic to causing severe symptoms. So we should know that our relationship with microbes is such that most of the microbes are never pathogenic. They don't have that virulence mechanisms. They don't have pathogenicity enough to cause harm to humans. many microbes are potentially pathogenic. Then that means they have a potential to cause harm, but in certain situations only. For example, if there is a breach of skin or mucosa, then they may cause harm. Otherwise, they are like sitting just like that. And on top of it, very few microbes are always pathogenic. Such microbes are strict pathogens. So coming on to the group called as resident flora, trillions of bacteria have evolved with and stayed within the system of human body. So we are more bacteria than humans. And this resident flora is the permanent resident of our skin and mucosal surfaces. Resident flora is not easy to wash off, and even if it is scrubbed off, it re-establishes itself very easily. What is the purpose of resident flora? Anyone? The resident flora, first of all, it competes with the pathogenic bacteria. Second, it produces certain toxic metabolites, which again have a harmful effect on pathogens. Third, anything? Anything else? You have something in mind? You were saying something, no? The guy in the second row from last. No? Okay. Basically, resident flora has a purpose of competing with pathogens and does not let pathogens harm us. Then there is a thing called as transient flora. Transient flora is basically this is the microbiota which stays, which does not stay permanent. It rather persists for a few hours or days or weeks. And transient flora is acquired from the environment. It is not indigenous to the human skin and mucosa. So whenever the resident flora decreases or is harmed or is disturbed, the transient flora outgrows it. It quickly colonizes itself and proliferates to cause disease. And this resident flora, normal flora, if introduced into a new habitat, it may cause disease. Okay, so an example when the normal flora introduced into a new habitat is causing disease. From gut, from any side? No? For example, if the gut mucosa is breached due to any reason, the gut bacteria, the microbiota within the gut, it crosses the mucosa and reaches the bloodstream. So the pathogens from the gut, like Escherichia coli, Klebsiella, they cause bloodstream infections. So there may be many reasons for breach of mucosa. So this is the chart showing normal flora of various parts of human body. Everything which is skin is colonized by pons. Pons is a group of staphylococci, that means gram-positive cocci in clusters, which are coagulase negative. These are coagulase negative staphylococci. Coagulase negative staphylococci means when we identify staphylococcus, we do a test called as coagulase test. If the coagulase test is positive, we label it as Staphylococcus aureus right away. And if it is negative, then there are many species of Staphylococcus which come under this category, which give a negative coagulase test. Like Staphylococcus. Anyone who can give an example of forms? Staphylococcus epidermidis, Hemolyticus, Saprophyticus, and there are many other species. So cons is one of the most important normal member of normal flora from skin. Other than the diphtheroids, Streptococcus species, Enterococcus species. Then there are certain analogs also. Propionibacterium, Peptostreptococcus. Anyone can tell Propionibacterium? You must have heard of it. Yes, acne. It has been implicated in position of acne. Then Candida. Candida species, it is a fungus, yeast fungus, and it is a normal inhabitant of skin folds. Okay. So whenever infections of skin and surrounding tissue occurs, like gangrene, necrotizing fasciitis, and cellulitis, the etiology is a mixed flora. Next, we come to upper respiratory tract. Upper respiratory tract, again, we have diphtheroids. By diphtheroids, I mean diphtheria-like bacteria. Diphtheria is caused by Corynebacterium diphtheri, right? And there are certain other similar bacteria which do not cause any disease, or they may be harmful in immunocompromised patients only. So these are categorized under diphtheroids. Okay, they are Corynebacteria species only. So cons, diphtheroids, Streptococcus viridans, again, these are the normal inhabitants of upper respiratory tract. And periodontal infections, sinusitis, mastocytitis, caries, these all infections are due to mixed oronasal flora. Then aspiration of saliva. You know that in mouth there are multiple anaerobes also, including Prevotella species, Fusobacterium, and then there are actinomyces on tonsillar pillars and gingival surfaces. On tooth surfaces, there are various streptococci, which are together grouped into streptococci viridans group. So all this, the aspiration of such secretions may result in aspiration pneumonia due to necrotizing pneumonia and or lung rupture due to mixed anaerobes. Okay. Then GIT. In GIT, the members of normal microbiota are members of Enterobacteriaceae family, like Escherichia coli, Klebsiella species, Enterobacter, Citrobacter species. These are gram-negative bacteria. Other ones are Enterococci and Streptococci. And anaerobes, towards when we move towards pollen, almost 96 to 99% of the microbiota is composed of anaerobes. And the anaerobic members are Bacteroides, Fusobacterium, Lactobacillus, Fugia. Some protozoa like entamoeba also may colonize gut and candida. Okay. Special remark is that stomach has acidity. Only Helicobacter pylori has been shown to persist in such acidic environment. Another thing is whenever we overuse antibiotics, these antibiotics suppress the normal flora, which results in overgrowth of Clostridium difficile, which is a normal inhabitant of gut, but it is not in that amount. So it overgrows and causes disease. What are the symptoms of C. difficile infection? Dysentery, right? Pseudomembranous colitis, toxic megacolon, all these entities come under CDM. Then urethra and genitalia. Anterior urethra is in continuation with the skin, so it has microflora containing skin organisms also. Pons and dipteroids, you must remember. Then vagina, it has group B streptococci, which is called as Streptococcus agalacti. Streptococcus agalacti you must have heard of. It is a frequent colonizer of vaginal tissue in females, and it has been implicated in causation of neonatal sepsis, early onset meningitis. Next, there are certain anaerobes like Streptococcus, Prevotella, Clostridia, Gardnerella vaginalis, Mobilanthus. These species together, actually, what happens? There is a condition called as bacterial vaginosis. Normally, what happens? Lactobacilli are more in number, while other anaerobes like Bacteroides, they are less in number. But during bacterial vaginosis, due to either change in pH or other conditions, the lactobacilli content decreases and Bacteroides increases. So bacterial vaginosis is a dysbiosis of vaginal normal flora. So what do we do when we encounter these resident flora or the normal commensals in our cultures? We report them as NPG. You must have read it on a sputum culture report. It means no pathogen growth, because sputum will always have oral flora in it, right? So some growth has to be there, but there was no pathogen which was seen, so we reported as NPG. Then in stool bacterial culture also, you must have come across NEPG report. NEPG means no enteropathogen growth. That means no bacteria which can be a pathogen in gut has been observed. And there are certain scenarios where even normal flora is absent. So we report it as sterile after said hours of incubation, and even normal flora is absent. Why do we report it like that? Because we want to get the clinician to know that even the normal flora is absent. Either antibiotics have been overused, or there will be some other reason. Okay. So coming on to the opportunistic pathogens. What are opportunistic pathogens? These resident flora members or otherwise harmless bacteria, which do not have potential to cause infection or symptoms in a immunocompetent patient, may become pathogenic following a perturbation to their host. Perturbation means a deviation from the normal equilibrium. Right? So in case of disease or medication like chemotherapy or malignancies or steroid use, diabetes, immunodeficiency, HIV/AIDS, and aging, these are all conditions which pose a risk to acquire opportunistic infections. Can you name some opportunistic infections? What?
You can use your mic actually. And turn on your mic and say it. It's easier.
Cryptosporidium isosclerosis. Yes. Even cryptococcal meningitis is an opportunistic infection by cryptococcus. Toxoplasmosis. Then coming on to strict pathogens. These bacteria, if encountered in any cultural board and seen in any smear, they're always considered as significant. These are Mycobacterium tuberculosis, Neisseria gonorrhoeae, which is the positive agent of gonorrhea, rabies virus, and Plasmodium species. Okay. Plasmodium species, which causes malaria. So I made a list of gram-positive and gram-negative bacteria. I heard that many of the residents cannot remember what is a gram-positive and what are gram-negative bacteria. So all the gram-positive have been mentioned in purple color, and all the gram-negative have been mentioned in pink color. So all the cocci you come across routinely, like staphylococci, streptococci, enterococci, even pneumococci, these are all gram-positive. Okay, and all the gut pathogens, gut normal gut also, they are gram-negative bacteria, most of them. So like Escherichia coli, Salmonella, Vibrio, Shigella, these are all gut inhabitants, right? Pathogenic or commensal, but they are in the gut. Shigella, Citrobacter, Vibrio, Campylobacter, these are all gram-negative. So apart from most of the important pathogens are facultatively anaerobic. Aerobes means they can survive in oxygen environment with oxygen. Anaerobes means they don't survive in environment with oxygen. Facultative anaerobic means they can survive in both situations. So most of the pathogens are like that. This is Staph aureus, Escherichia coli, Klebsiella. Strict aerobes are Pseudomonas, Vibrio. They are strict aerobes. They require oxygen for their survival. Coming on to the anaerobes. I've already told you that they are inhabitants of various skin and mucosal sites, like especially in colon, gingival crevices, urethra, vagina, and tip surfaces. And they are pathogenic if they are displaced from natural habitat. They multiply well in dead tissues. Their blood supply is cut off either due to trauma or obstruction or surgical manipulation. And all these anaerobes are naturally resistant to aminoglycosides and quinoline. The important ones which you will come across as a clinician will be Bacteroides species, Fusobacterium, and Clostridium difficile. Okay. So let's go for a concept check. A 47-year-old female presents with a 5-week history of fever. She had hypertrophic obstructive cardiomyopathy. On examination, dental caries were also found. And recently, she underwent dental extraction. On transesophageal echocardiography, vegetations were seen on half valves, and blood cultures grew gram-positive cocci. So what could be the likely organism? Mike. To the mic. It is not a test. You can always guess whatever is having in mind.
Strep viridans.
What?
Streptococcus viridans.
Yes. Why?
It can pass through vegetation and infect the heart valve.
The main dental caries. Okay.
Extraction during extraction.
And thus, she had dental caries.
Yes.
So the tooth surfaces, the dental caries on the tissue around it, has streptococcus tissue as a normal resident flora. During the extraction process, what would have happened? There must be, the patient might have had a transient bacteremia due to the bacteria around the tooth surfaces. That transient bacteremia led to healing of the valve. So hence, streptococcus viridans will be a closing valve. Although the Biotechnology have also can also cause in such cases endocarditis, but because of the history of dental caries and dental extraction procedure, we will go towards Streptococcus viridans. Next, a 70-year-old man with history of diverticulosis of sigmoid colon experiences a sudden onset of severe left lower quadrant abdominal pain and fever. There was abdominal tenderness also. A diagnosis of probable ruptured diverticulum was made, and an abscess next to sigmoid colon was also found. The most likely bacteria are
It's to GI flora.
yes. Why?
So there is a rupture of the GI
All the bovine contents must have spilled into the surrounding tissue. And during the acute phase, it is peritonitis kind of thing, and later on it gets into an ulcer, forms an ulcer. Initially, it has E. coli also and mixed anaerobes, but during abscess stage, it has mainly bacteroidal species plus other organisms also. So answer will be mixed GI flora and anything. Okay, let's go to a fact check. False about pneumonias. More than 80% of the community acquired. See, here we'll talk about community acquired pneumonias only. As such, hospital acquired infections, you'll be having a class later on. So first is more than 80% of community acquired pneumonias in infants and children are due to viruses. Second is most commonly associated bacterial agent is Streptococcus pneumoniae. Then 10 to 20% of community acquired pneumonia in adults are due to viral etiology. Third is atypical pathogens are Mycoplasma pneumoniae, Legionella, and Chlamydophila. Fifth is aerobes are usually responsible for aspiration pneumonias. Now, after resident flora and opportunistic pathogens and strict pathogens, we now come to sites which are always sterile, considered as sterile. These are blood, cerebrospinal fluid, CSF, synovial or pericardial fluid, and deeper tissues. Growth of any organism from these sites are always considered as significant, except when the organism is of doubtful significance. For example, ponds, coagulase negative staphylococci, which are like normal inhabitants of skin. So, what do we do if such scenario happens? To ascertain if it is significant or not, we send multiple cultures. Growth of same organism from multiple cultures at multiple times is considered to be a significant. Plus, patient should have suggestive clinical signs and symptoms also of the disease. Okay. And there are certain risk factors also for cons infection, like devices, presence of catheters, immunodeficient states. All these are important while considering significance of cons from a bloodstream infection. So let's go to another question. Normal flora is absent from gut, pharynx, lungs, hair follicles, and mouth. Yes, lungs is right. Gut and pharynx, you don't have any doubt. Mouth, you don't have any doubt. Hair follicles have flora similar to skin, and propionibacterium is one of the common anaerobes. So lungs, the deep tissues, they are sterile. So next question is a 37-year-old woman who has a history of recurrent UTIs and presents with burning micturition along with the frequency emergency. She also states that her urine smells like that of ammonia. What could be the likely organism in this case? Yes, good. In any kind of UTI, Escherichia coli is the most common organism which is implicated in UTIs. But since the patient is giving history of smell like ammonia, we'll go with Proteus tissue. Find correct pair. First is acute laryngitis is always almost always due to viral etiology. Epiglottitis is usually due to bacterial etiology. Acute suppurative parotitis is usually due to mumps virus. And pseudomembranous membrane formation over tonsillar fillers is due to diphtheria.
1, 2, and
Correct pairs? Only 4? Not all.
third is also.
What? Somebody said 3. Not 1, 2, 3. 1 is correct, 2 is correct, 4 is correct, 3 is incorrect. Acute suppurative parotitis used to be due to mumps virus in earlier years. Now, with the introduction of a very good vaccine, we have Staphylococcus aureus, which is implicated. Most common name, acute suppurative parotitis cases. Okay. Next, traveler's diarrhea is mainly caused by Escherichia coli, Shigella, Vibrio, Campylobacter. Yes, Escherichia coli. Diarrhenic Escherichia coli. Yes. Vibrio does not cause traveler's diarrhea that often. Shigella and Campylobacter have been implicated, but they are not that common. Next, etiological agents causing dysentery are Shigella, Campylobacter, Entamoeba histolytica. Yes, non-pathogen. Any example of non-typhoid salmonella species? What? Yes, typing routine, salmonella typing routine. So all these pathogens have intrinsic resistance to certain antibiotics, which we should know. All the gram negatives, first we start with gram positives. All the gram positives are resistant to astrogen, the monobacterium. All the gram negatives are resistant to glycopeptides. All the anaerobes are resistant to aminoglycosides. All the aerobes are resistant to metronidazole. Proteus is inherently resistant to colistin and nitrofurantoin. Pseudomonas is intrinsically resistant to tetracycline and ertapenem. Entropococci are intrinsically resistant to cephalosporins and aminoglycosides. And Klebsiella is intrinsically resistant to amphotericin. What is the advantage of knowing intrinsic resistance? Anyone? What? See, super easy. I told you it will be a super easy and super useful presentation. Next concept here. All the gram-positive bacteria show intrinsic resistance to. Yes, good. So I succeeded. Now, this is a chart showing distribution of various organisms from the bloodstream infection from our department during the previous 1 month. It has been shown in CVR also in January. So the most common organism isolated was Klebsiella pneumoniae, and at par were coagulant negative staphylococci. You can see on the left side of the pie chart. So cons are not considered significant pathogens. That means the sample collection, there must be a sample collection problem because we have to take aseptic precautions. If we do not take precautions, we do not clean the area, then cons will like recover cons. And after Klebsiella pneumoniae, E. coli. That means we are heading towards a gram-negative majority from bloodstream infections. Gram-positive are on the lower side. Staphylococcus aureus, you can see only 9% of the cases we have isolated Staphylococcus aureus. The most important pathogens in our hospital are Klebsiella pneumoniae and Escherichia coli.
Not enteric fever like typhoid. You're not getting salmonella.
Once or twice in 2 months.
Very interesting.
Then from urine, the most common isolates have been found to be, I told you, E. coli is the most important and most common positive variant of UTI, followed by Klebsiella pneumoniae, other organisms. From respiratory samples, Klebsiella pneumoniae, Acinetobacter, and Pseudomonas aeruginosa, they form the majority of respiratory tract infections. So after bacteriology, we will now come to the second group, viral infections. Just a little bit about viral infections. All are DNA viruses except what is the coronavirus?
RNA.
RNA. Which group is at increased risk for herpes zoster? One, patients with advanced. This statement regarding dengue is not true. First, it is mosquito borne. Is it? Which mosquito? Aedes, yes. Aedes aegypti and Aedes albopictus also. It is distributed in tropical regions. Fourth case has a single antigen. It is the correct answer. It is the statement is not correct, but answer is correct. Yes. How many antigenic types are there? Four. And infection with a single antigenic type gives a lifelong immunity to that serotype. But not to others.
But increases the mortality with the other.
Next, a 34-year-old man develops fever and focal neurological deficits. MRI shows the left temporal lobe lesion. Which test will be most appropriate to confirm the diagnosis? Yes, PCR for which viral DNA? Next, we move on to fungal group of infections. I've already told you they are classified as yeast or mycelial fungi. you have given examples also. So if we see the pictures, these are yeast cells, and they give rise to another yeast cell by budding. Okay, so this is a Candida or Saccharomyces. Cryptococcus looks like this. What we do, Cryptococcus has a big capsule. So we stain the background so that we can visualize the capsule. It is negative staining, India ink staining also. So we see these yeast cells, round yeast cells surrounded by a clear halo. Okay. And these are Cryptococcus in LPCV mount. There is another staining which will where these cells appear blue. Then these are Aspergilli filaments, and these are dermatophytes, which have very thin filaments, plus they have spores also, macrocomedia, which are distinguishing features of one species from other species. So now coming on to infections due to Candida species, it is a normal flora in skin, mouth, gut, and vagina, and it overgrows to cause symptoms when immunocompromised conditions occur. For example, from steroid use, diabetes mellitus, malignancies, HIV, etc. So this is oral thrush, esophageal candidiasis, then vaginal candidiasis. The infections range from oral thrush to esophageal candidiasis, vaginitis, diaper rash, and even bloodstream infections. Can you name some emerging Candida species? Auris and then infections due to Aspergillus. We have like 4 or 5 important species. Aspergillus fumigatus is the commonest one, followed by flavus and Tegius. And infections occur in immunocompromised population or in the patients who have underlying lung disorder. So we are like every day we are exposed to the spores from these mycelial fungi, but we do not get disease, we do not get symptoms because our immune response is still intact. But when the person is immunocompromised, then these single spore also can cause a severe infection. So aspergillosis may be bronchopulmonary, rhinosinusitis, cerebral mass also, then endophthalmitis, cutaneous aspergillosis, or disseminated aspergillosis. Aspergillosis responds very well to voriconazole and amphotericin. Then is mucormycosis. Most common form is rhinocerebral. You must have heard of black fungus during COVID times. This COVID-associated mucormycosis. Many patients who received steroids and who were diabetic, they had this fungal infection. The rhinocerebral mucormycosis presents with the localized swelling of the structures around eye, and it is generally limited to one side of face. And there is blackening of the infected tissue. The fungus is not black, actually. The name is a misnomer, black fungus. The necrotic tissue and the affected tissue appears black. Okay? That is why it was named as black fungus. And other entities which it can cause are primary cutaneous disease or pulmonary mucormycosis and gastrointestinal mucormycosis. The mucorales, the agents of mucormycosis, respond very well to amphotericin B, posaconazole, and isavuconazole. Okay, but you should always remember which fungus is intrinsically resistant to which antifungal. So, if we talk about fluconazole, which is a very commonly prescribed antifungal in OPD basis, we should remember Candida krusei and many strains of Candida glabrata, Aspergillus species, and mucorales are intrinsically resistant to fluconazole. That means fluconazole will not work in these cases. Then voriconazole, which is a drug of choice for invasive aspergillosis. Mucorales, the whole group is resistant to voriconazole. Okay. Then amphotericin B. There is one species of Candida called as Candida lusitani, and one species of Aspergillus called as Aspergillus tevius, which have intrinsic resistance to amphotericin B. Then echinocandins. Cryptococcus neoformans is one yeast which is intrinsically resistant to echinocandins. Otherwise, echinocandins are very good group of antifungals. Okay, and that was all about it.